Good morning, good afternoon, everybody. I'm Ellen McKenzie. I'm chair of the Department of Health Policy and Management here at the school. And I want to particularly welcome all the new MPH students here. I know there are several of you here, and you're in for a great year, believe me, and we look forward to working with you very closely. Um, I'm here to welcome you, to be the first one to welcome you to the first in a series of conversations with our Centennial Policy Scholar, Congressman Henry Waxman. The Policy Scholar Program was established in the Department of Health Policy and Management with the goal of bringing policy leaders to the school to interact and engage with students and faculty throughout the school and the university. It is made in it's made possible in part by the generous contribution of one of our alums from the department, Frances Henkel, who got her doctoral degree in 1985. And we're so very grateful to Frances for helping us make this possible. So I can think of no better person than Congressman Waxman to kick off this centennial year and to celebrate this landmark in our school's history. The Congressman is arguably the most accomplished legislator of our time and a true champion of public health. We are thrilled and honored to have him and to learn from him throughout the year. The Centennial Policy Scholar Seminar Series will be held monthly. We'll have a seminar every month in the coming year. And each month we're going to address a particular challenge in public health, including topics such as aging in America and long-term care, mental health and addiction services and policy, HIV and AIDS prevention, tobacco policy, among others. So we look forward to the Congressman's perspectives on these issues and how together we can move forward in assuring that effective policies are in place in the future to address these challenges. I urge you to go to our website. You can go to the website of the department and click on news and events. It's kind of buried there. We're going to try to bump it up a little bit, but go to news and events, and there you'll get all the information on the Centennial Policy Scholar Series and the topics and the dates moving forward. So it is now my pleasure to introduce Josh Sharfstein, who's the Associate Dean for Public Health Practice and Training here at the school, also a professor in the Department of Health Policy and Management, and he will officiate over today's program. As I think many, if not most of you in the audience know, Josh has held many senior positions at the local, state, and national levels over the years, most recently serving as Secretary of Health and Mental Hygiene for the state of Maryland. But what you may not know is that, and I think it's probably your first real job after you finished your medical training, was working with Congressman Waxman. So he broke Josh in. So we have a lot, we have a lot to thank Congressman Waxman because we treasure Josh, and we're just thrilled that he is now part of the School of Public Health. So without further ado, Josh is going to come up and give you an overview of today's event and introduce our speakers. And again, let me just say thank you for joining us here today, and we look forward to seeing you at the next seminar. Thanks.
Thank you very much. It's great to be here. It's great to be part of what is really a remarkable group of people who are going to be talking about a remarkable program in Medicare. I really want to thank Professor McKenzie for her leadership at the school and her leadership in setting up the Centennial Policy Series, and Dean Clagg, who wanted us to pass along that he is sorry he's in transit today and couldn't be here, but his strong support also made it possible. I'm going to be introducing people as they get up to talk. I will say it is true that my first real job was working for Congressman Waxman, but it didn't feel like a job. It felt like a fabulous graduate program. And I learned so much from him and from the other staff. And one of the things that we'll be doing, starting with today, is actually at these seminars bringing not just Congressman Waxman for his perspective, but some of his staff who have gone on to work in depth in different policy areas. But first I want to turn to Professor Karen Davis. The way we're going to organize this is Professor Davis is going to give an overview of Medicare, to be followed by a conversation between her and Congressman Waxman. For people who care about Medicare, Karen Davis talking to Congressman Waxman is a little bit like, when Picasso met, Van Gogh or something like that. It is really like two legends talking to each other about Medicare. So we just finished a webcast that was just fantastic. I was trying not to just, let my jaw hang open during the conversation that I was watching. So I think that'll be great. And then we're going to have a tremendous panel talk about Medicare, past, present, and future. We've got with us here some of the nation's and world's best experts on Medicare, including the director of the Medicare program now, in Sean Kavanaugh, one of the leading analysts and congressional staff and experts on Medicare, and Sheila Burke, and someone who has been involved in critical moments of Medicare now and in the future, and Jack Giebler. So we have just an unbelievable day. Just to start with Professor Davis, you may know her as the Eugene and Mildred Lipitz Professor in the Department of Health Policy and Management. That is her official title at the school. She's also the director of the Roger C. Lipitz Center for Integrated Healthcare at the school. But she has had an unbelievable career in health policy that really does make her a legend. She's been the president of the Commonwealth Fund, the chair of the Department of Health Policy and Management at the school, and the deputy assistant secretary for health at the Department of Health and Human Services. She also most recently oversaw the creation of a series of seminal policy papers about Medicare at 50 for the Commonwealth Fund that you can get off the Commonwealth Fund's website. So I could go on, but I think we want to jump into it, so I'll ask Professor Davis to come up. Thank you.
Thank you, Dr. Sharfstein, for that introduction, and to all of you for being here to help us celebrate the 50th anniversary of Medicare. Medicare and Medicaid enacted in 1965, following on the heels of the Civil Rights Act in 1964. And 80 years ago, the Social Security Act represent together an enormous commitment to improving the health opportunity and economic well-being of many of our most vulnerable citizens. So I'm going to share with you in, I hope, 5 minutes, some of the highlights of what Medicare has accomplished, what its future challenges. I gave it in 2 hours yesterday to the incoming masters of public health, but we'll try to spare you that. But in short, Medicare has achieved its goals of providing health insurance coverage to people over age 65 and the disabled, and ensuring that they can get health care, get quality health care, and they're protected from the financial burden. It's amazing to think about that almost half of older people were uninsured before Medicare was enacted. Today, people are talking about the Affordable Care Act and reducing the uninsured rate for those under 65 from something like 18% to something like 8%. Medicare basically provides health insurance coverage to everyone over age 65, certainly those covered by Social Security. The surveys that we did at the Commonwealth Fund and been done by other organizations show that Medicare beneficiaries uniformly rate their health insurance coverage better than people under 65 in terms of their ability to get needed care and protecting them against medical debt and burdensome medical bills. Some people say Medicare is an anachronism. And there are parts of it that still haven't been changed and need to be changed, but really it's a record of innovation over time. When it started, Medicare adopted private insurance practices of paying hospitals based on costs, thanks to Dr. Jerry Anderson, who developed a new prospective payment method called the DRG, Diagnosis-Related Group Method of Payment. Medicare now rewards hospitals that are able to provide better care with shorter lengths of stay, and that method is now used by not only private insurers, but 40 nations around the world. Medicare also adopted in the 80s a physician fee schedule based on the relative value of work. I see Jonathan Weiner in the audience. Much of the research on the content of medical practice has gone into these reforms. Lauren Nicholas on the faculty here has done research on Medicare Advantage. We talk a lot in this country about health insurance exchanges. Medicare offers both private insurance and traditional Medicare to its beneficiaries, and does so in a way that gives people choice, but also rewards through a 4- and 5-star program people who select high quality, high value plans. And Medicare's been a leader in reporting on quality. You can actually look up the mortality rate of the hospital that you go to, its infection rate, as well as how other patients rate their experience. So a real leader in innovation, and that's being accelerated with the Affordable Care Act, which has established, as I'm sure we'll hear from Sean Kavanaugh, a Center on Medicare and Medicaid Innovation with $10 billion over 5 years to test new promising approaches to healthcare delivery and payment. The net result, Medicare has struggled with costs, as the entire healthcare system has struggled with it over the last 50 years. But right now, Medicare spending per beneficiary is growing at the slowest rate that it's grown in 50 years, slower than the economy as a whole. People who know me know that I focus on the future, not the past. So that's the good news. I want to talk a little bit about the challenge to set up our panel. The Commonwealth Fund in 2014 did a survey of people aged 65 and over in 11 countries. And despite all that Medicare has done, the truth of the matter is older people in America pay more out of pocket for their healthcare expenses than similar people in other countries, and report more problems with access to care, certainly, than in countries like France, Switzerland, Australia, and Canada. And the real problems are focused on people with incomes less than twice the federal poverty level. We have Medicaid at the very lowest income levels that supplement Medicare, helping pay premiums and cost sharing. But for those with modest incomes living on Social Security checks, almost half, 40 to 50%, spend more than 20% of their income on healthcare expenses. Colleagues here at Hopkins and recent graduate Christine Boutorf have put together a proposal to really improve Medicare benefits, integrate them into a single plan, and have sliding scale premium assistance to make sure that everyone can afford care as the population ages, while at the same time giving people an incentive to choose high-value providers. A second major challenge with the Medicare program, the boomer generation born after World War II started going into Medicare in 2011, became 65 starting in 2011. In 2021, they're going to start being 75. And as the population ages, the numbers of chronic conditions, the limitations that they face in being able to take care of themselves, whether those are physical limitations or cognitive limitations, will increase. Already 9 million Medicare beneficiaries living at home, or 17% of all Medicare beneficiaries, have either physical or cognitive limitations and need assistance really carrying out their activities of daily living. Again, colleagues, experts elsewhere, as well as colleagues here, including Eileen Holland, doctoral student Lauren Nicholas on the faculty, have developed a proposal for Medicare to cover home and community-based services to better enable people with physical or cognitive limitations be able to realize their preference for continuing to live independently. Such services would be provided by organizations that would go beyond the accountable care organizations created in the Affordable Care Act to really reward organizations regulations that are able to reduce nursing home placement and keep people at home and let them share in the savings of reduced future long-term care services. Obviously, that's going to require an intensive period of testing to develop that concept. Jerry Anderson and others of us have worked on some of the issues about continuing the movement of Medicare from fee-for-service payment, volume-related payment, to value-related payment, accelerating the adoption of global methods of payment, bundled payment, blended payment for primary care. Dr. Anderson has also argued that that'll be most effective if we combine it with price transparency on prices and quality so people know what to expect when they select a hospital or a doctor, and to also engage private insurers and Medicaid in working with Medicare. We'll soon have another report of the trustees of the Medicare program. The basic challenge that Medicare faces is the retirement of the boomer generation. That's certainly going to accelerate over the next 10 years the number of people covered by Medicare. But that was coupled with modern birth control methods in the 1970s, so we actually had a major drop in fertility rates in a subsequent generation. So if you look at the ratio of people who are retired to people who are working, that ratio is going up, or I'll show it the other way, the ratio of workers to people age 65 and over, that's going down pretty markedly. And the major source of financing, Social Security pensions, and Medicare health insurance for older people is an earnings tax. So as there are fewer people working, fewer dollars flowing into the trust fund. That's the bad news. The good news is, as I said, Medicare is growing at a very slow rate. In fact, the Congressional Budget Office has adjusted its projections of Medicare outlays from what it was projecting just 5 years ago to what it's projecting now. It has lowered those projections by $1 trillion over a 10-year period. To put that in perspective, the cost of covering the uninsured in the Affordable Care Act was $1 trillion. We actually could have financed it out of Medicare savings. The charge I gave to the Masters of Public Health students going forward is when they take a job working for the Congressional Budget Office, they are not to make $1 trillion mistake again in the projections. Didn't tell them how to do that. I don't think any of us quite understand why they were so far off. A combination of explanations, obviously. I think a lot of it's the transformation of the American healthcare system that even predated the Affordable Care Act, but certainly accelerated by the Affordable Care Act, as well as changes in the economy as a whole. So lots of challenges ahead, lots of issues for our panel to address. The fragmentation in Medicare benefits, that is pretty much the way it was from the very beginning. Separate part for hospital, physician, prescription drugs now, and the need to supplement that with private coverage. The fact that it doesn't cover long-term care. The fact that while we're testing innovative ways of paying, we're still largely paying on a fee-for-service system, and nobody yet knows how to resolve that difference between the growing retiree population and working population. So thank you very much.
Great, thank you very much for that. Brief introduction. I'm now going to introduce very briefly Congressman Waxman. For those who are just getting to know him, Congressman Waxman served in the U.S. House of Representatives for 40 years, ending at the end of last year, representing a district in Southern California. He worked in the Energy and Commerce Committee and the Committee on Government Reform extensively, chairing the Energy and Commerce Committee during the passage of the Affordable Care Act. Some of his many legislative accomplishments include the Ryan White Care Act for HIV, the Hatch-Waxman Act, or as we like to call it, the Waxman-Hatch Act, that established generic drugs, multiple expansions of the Medicaid program, which I think have led some people to say that Henry Waxman created the entire welfare state when nobody was watching. Major seminal improvements to the Clean Air Act and the Clean Water Act, as well as the Affordable Care Act. His oversight is also of legend of movies. He changed the way people perceive tobacco products in the United States and paved the way for tobacco regulation and other public health approaches to tobacco. In any one of these areas, it would be an amazing congressional career, but Congressman Waxman had them all. And as I said earlier, it was remarkable to me to see up close that someone of such courage and fearlessness also was so great and supportive to his staff, and had just his office was such a wonderful place to work. And recently there was a reunion for staff when he stepped down, and I think there were more than 200 people there, and probably we could have all been talking all night about all the different work that had been done. So it's a tremendous value to the school. We're deeply appreciative that you've chosen the Johns Hopkins Bloomberg School of Public Health to spend this first year after you're leaving Congress, and to help us learn from you. So thank you for coming, and I invite you to come up and join Professor Davis for a discussion about Medicare.
Well, you've had an extraordinary legislative career for the last 40 years. How would you put Medicare in the context of important social legislation in the 20th century?
It's one of the great accomplishments I had nothing to do with. Medicare and Social Security are the social services programs that are enduring and will hopefully continue to endure. They're programs that were based on the idea that we're not going to say only some people would have access to it. We'd say everybody has access to it. You pay into your Social Security when you're working, you pay into the Medicare fund while you're working, and then you're eligible, you're entitled to those benefits when you reach a certain age, not always 65, because it's much older if you wait for your Social Security benefits, but it's 65 for the Part A Medicare program, and then you're eligible at that time to buy Part A, Part B, and D. But these are essential programs that protect people in this country from what we saw happening before there was Medicare. Before there was Medicare, as you pointed out, one of the fastest growing groups in poverty were seniors. Less than half the seniors had any kind of health insurance. The insurance that they cared the most about at that time, and it was 1965, was hospital coverage, because they figured they could go see their doctor. Healthcare drugs weren't that much of an expense, but going to a hospital was the thing that they feared the most. And President Kennedy and then President Johnson were aiming to make sure that every senior had access to health care coverage for hospitalization. The AMA at the time was very much against the idea. They said, we don't want you to interfere with the doctor-patient relationship, which to them meant only one thing, a private practice with a patient coming in and paying the bill. And they were very much against it, but members of Congress at the time said, well, we ought to cover physician services as well, and they adopted Part B of Medicare, but they didn't make it a payroll system the way Part A was designed, where people paid into it during their working years. You had a choice, and it's still true today, you have a choice of enrolling or not enrolling in Part B. It's a bargain that is hard to say no to, because people pay 25% of the costs for physicians and other services under Part B, And then the taxpayers under the general fund pay 75% of the cost. So it's a pretty good deal. It's hard to turn down. And however, while most people sign up for Part B, there are a lot of out-of-pocket costs before you could get the benefits under Part B. There are deductibles and co-insurance. So most people that have Medicare also go buy a supplemental policy to help cover some of those other costs. And in that context, we had a situation in Congress where people were buying supplemental policies that were very limited, in some cases worthless. People would say, what do I fear the most? Well, God forbid I should get cancer. I'll buy cancer insurance. So if I get cancer, they'll pay the costs. And then, of course, they have a heart attack or they get some other disease, and they're out of luck. They have to pay all the out-of-pocket expenditures for B, and their out-of-pocket expenditures for A. So we, as a federal policy, said supplemental policies have to cover the needs of people, and filled in the details. So anyway, that's a long answer to your question. Medicare is a fundamental protection for security for people when they get older and or disabled for over 2 years to be able to get access to needed medical services. And we built it up and changed it over the years. It's different now than it was in the beginning. And it's certainly going to be much more different in the future under some of the experiments that we called for in the Affordable Care Act to look at what is the best way to organize healthcare services and meet the needs of a growing elderly population.
You know, obviously, the other part of that legislation in 1965 was the Medicaid program.
Yeah.
How important would you say Medicaid is to supplementing Medicare?
Well, it's essential for seniors who are not all well-to-do. There's some image that seniors all have a lot of money, and therefore they don't have anything to worry about. But the reality is that you would know the statistic, large numbers who live on Social Security. What would it be?
I think that the average income, 50% of Medicare beneficiaries would have incomes below $22,000. So they're basically surviving on a Social Security check.
So it's not a lot of money to live on, and the medical costs increase even with Medicare. So out of concern for lower income seniors who couldn't even meet their Part B fees or their deductibles and co-insurance, we provided a supplement through the Medicaid program. Medicaid, by the way, started, and we'll have another session at another time, but Medicaid started as a program only for the welfare recipients. You had to be on welfare to get Medicaid coverage, and so it was aid to the aged, and to be in Medicaid, you had to have a very low income and very low assets test. And then Medicaid supplemented Medicare to help people with those costs that make them eligible for the full benefits under the Medicare program.
And obviously Medicaid picked up nursing home care as well.
That's been the blind spot. You know, people thought about hospital costs. They didn't think about doctor's fees. Then we covered doctor's fees, and it got to be a lot more expensive. But in this country, people think that Medicare now covers all the medical needs they're going to have for the rest of their lives. They're often in for a very rude shock, because if you have to go to a nursing home, if you need that level of care, Medicare will pay for it for a short period of time after a hospitalization. But if you want to stay at home and need somebody to come and just help you with non-medical services, but services that nevertheless that are needed, there are some things covered under Medicare, but most of it is not. And the way people get access to what we call long-term care on the spectrum of help at home, help in a daycare program, help in an assisted living, or help in a nursing home, they have to go on Medicaid. And Medicaid is a poverty program. It was originally a welfare program So people had to find that they had to use up all their savings. And most of the people in nursing homes are under Medicaid. Many of them came to a nursing home when they had some money, but they had to use it to spend down to the point where I think in most places it's less than $2,000 that they have left. And that is so dehumanizing for people, to realize that whatever they've worked for all their lives, that maybe a little money they wanted to pass on to their children and their grandchildren, they have to use for their health care in the nursing home if they need that level of care. So the unaddressed problem is, what do we do for long-term care? A lot of people figure they can buy supplemental insurance, buy insurance for long-term care. We tried to move in that direction in this country. It hasn't been as successful as you might imagine. A lot of people think, well, they'll go on Medicaid, or they'll never need it. And so most people in nursing homes end up on a Medi-Cal, or they're able to pay for themselves, so they're private pay patients. But Medicaid becomes the program for Medicare and others when they are poor enough to qualify for it.
Well, obviously, the other big gap in the Medicare benefit package are prescription drugs.
Yeah.
And it wasn't until 2003 and Medicare Modernization Act that Medicare moved to cover prescription drugs. Why was that so slow in coming?
Again, the cost of drugs weren't that high. People would go to the drugstore, buy something over the counter, or they had a prescription, they bought a drug to help them along. But the pharmaceutical costs were going up as the pharmaceutical industry developed a lot new medicines, and people were struggling with it. Of course, the older you get, the more you have medical problems, the more costly it is to buy the drugs. And people were unhappy with it. They were struggling with it. I think that we deserve a little credit in our committee, because on our committee, when we were in the minority, we couldn't set the agenda. And the Republican majority was doing all sorts of investigations to see whether President Clinton was trading secrets to communist China. I mean, they really did investigations on that. And also the chairman of the Oversight Committee was holding hearings about how vaccines cause autism and giving a platform for all the scares that have resulted in lower vaccination rates. They weren't looking at a lot of things that we thought were important. So I asked the staff to do some reports. And we did reports that we could give to individual members. You know, when you're trying to develop working relationships with your colleagues, there are a lot of ways to do it. You can be friendly. You hope they'll be friendly back. You can help them in their campaign and hope that they'll remember that when they're elected or re-elected. If you're a chairman of a committee, you can give certain legislation for somebody to carry. And I was aware of all those things, but I thought one of the things we could do to get the majority back was to give people some issues that they can get attention on. And so we did individualized reports that members could go home and announce. And we did a series of reports illustrating that the cost for medicines in this district, in this area, in this town, were twice as much for people on Medicare where there was no coverage than what their neighbors had when they had coverage in their insurance plan. And people said, that's right. I have to pay more for my drugs than I have to pay for all of the costs. And then we got such a strong reaction to that, we did another report and gave it to members to show how if you bought the same drug in Canada, it was a lot cheaper. Or if you bought that drug in Great Britain, it was a lot cheaper. And since these reports were so popular, we even did a report on how if there was a drug that you could use for animals and people, the cost for buying the drug for the animal was a fraction of what it cost to buy that same drug to use for people. So in effect, at the grassroots level, people were getting agitated about the high cost of drugs. And President Clinton proposed covering pharmaceuticals under Medicare the way we cover everything under Medicare. It's provided as a benefit, and it would probably have been under Part B. It would have been something where the government would say you can get your drugs, and we would pay the cost of those drugs. We'd negotiate the price. We would set a price. Well, he wasn't able to get his bill through. But the Republicans said, maybe we can do a Nixon goes to China. We can get the tremendous political benefit of providing pharmaceutical coverage for seniors. Well, that would have been a tremendous coup. And what they decided to do was to set up a benefit unlike any that we've ever had under Medicare. To get your drugs covered, you had to go buy a private insurance plan. You had to be in Medicare, but then you had to go into Part D, and if you had Medicare fee-for-service, you had to buy a private insurance plan to cover your pharmaceutical costs. Or if you were in a managed care plan, that managed care plan could provide for drug coverage. So you could get your drug coverage in one of those two ways. But in order not to offend the pharmaceutical companies, they wrote in the law that the government may not negotiate the prices for drugs, which of course is amazing, since now Medicare is going to buy drugs for millions of people. You would think the government would say, wait a minute, you should give us a better price. We're bringing you a lot of customers you never had before. The government was prohibited from negotiating prices. So they benefited the pharmaceutical companies by letting them charge what they could get away with, and they benefited the insurance companies by having them run the program. And that's the way Medicare Part D is run today. People love it. They love it because they finally have coverage for pharmaceuticals, but it could have been done in a much more cost-effective way. And someday we may go back to that. If I could give you an example, under Medicaid, healthcare for poor people, low-income people, we said to the drug companies, if you're going to provide drugs at a discounted price for a best price for some people you want to entice to use your drugs. For example, the pharmaceutical companies would go to a managed care plan and say, we will sell you these drugs at a lower price than what other insurance companies will pay. We're going to give you our best price. So some members of the House at the time, one of whom was Ron Wyden, said, well, why should they get a best price? And the government buying drugs for low-income people won't get that best price. We should get the best price as well. So the Medicaid drug benefit for veterans and for Medicaid was based on the best price. So when the pharmaceutical Part D was adopted for Medicare, they took the people who were both eligible for Medicare, because they're elderly, and eligible for Medicaid, because they're poor, and the drugs they bought under Medicaid were now considered drugs to be bought under Medicare, so that the pharmaceutical companies would get huge amount more money for the same drugs. So they're buying sometimes literally same drugs for the same people who were both on Medicare and Medicaid, but now paying a higher price because politically it was something that they decided to do. Now, you would say, how could Republicans do that? One, they're against entitlements. But two, they're such fiscal conservatives. This is an expensive proposal. It cost $400 billion. They didn't pay for any of it. They paid for it out of the deficit. They said the government will provide it, and it's a cost, and it's going to be not going to be paid for. Contrast that with the Affordable Care Act, where every cent that we spent in the Affordable Care Act, we had to figure out a pay-for. And a pay-for could be a tax increase or a reduction in spending. And it was a combination of the two. We raised some taxes, such as I think we have a higher premium paid by working people under their Medicare benefit for the upper income. We have a tax on medical devices. We put a little tax in on some of the healthcare insurance plans, and then we made sure that we're holding down costs in other places. and the whole thing was absolutely paid for. We had to do that when Democrats were trying to pay for something big, but Republicans, when they did it, it was not an expense. They had a tough time passing it, but they passed it, and that's where Medicare Part D is today.
You talk about the affordable.
I think
I want to make sure we can.
not run out of time for
Yeah,
everybody
keep
else.
going. I'm going to give you one more question, Professor.
Okay.
You talked about the Affordable Care Act. A lot of people
Yeah.
thought we ought to, because Medicare was such a success, have Medicare for everyone, or at least a public option, make Medicare available as a choice. Why
Yeah.
didn't we do that?
Well, we didn't do it for Medicare for everyone, even though it was talked about as the first step for national health insurance in the 60s. Next was going to be kiddie care, where all the children were going to be automatically covered, sort of squeeze and eventually cover everybody. But we were already in the Vietnam War, and we were making choices between guns and butters, gun and butter, and we decided we didn't have enough money for that. And then after that, people were complaining about how expensive these entitlement programs were, so we moved beyond that. President Obama, on the Affordable Care Act, decided not to do anything radical. You wouldn't believe it for all the attacks on it. But he said, I will take the system as it is. I will be least disruptive. Most people have their insurance for their jobs. We'll leave that alone. People have Medicare. We'll leave that alone. If they're on Medicaid, we'll leave that alone. But what we're going to do is protect the people who couldn't buy insurance because they couldn't afford it. And we either put them in Medicaid if the states, we found out, had to go along, or we put them in an exchange where they could shop for different private insurance plans, which was something the Republicans put forward as an alternative to the Clinton health care bill, as a free market private insurance way of handling things. And so it was a very modest proposal just to fill in the gaps with the present system. What was also written into this ACA was to use the healthcare system to pull things together. And here is where Medicare plays a very important role, because Medicare has always been the leader for private insurance to copy for how they're going to reimburse providers. And we said, let's start paying more for quality rather than volume. Let's pay for managed care and affordable care organizations and unique experiments that can deliver healthcare more efficiently and more cost effectively, and then the private sector will pick up on these things. So the ACA and Medicare, Medicare before and now particularly, is going to be the place where the other insurance policies will look to for innovation as they have in the past, and will help drive the whole healthcare system.
Great. Well, on that note, I want to point out that there was a fabulous discussion that Professor Davis and Congressman Waxman had this morning that will be archived on the web, that you could see this kind of conversation for a little bit longer. But we're going to switch to the third and final segment of this panel, which is the panel, and I'll invite the panel discussion members up. I'll do a brief introduction. We're really honored to have all three of them here. Sheila Burke is a faculty research fellow and faculty member of the John F. Kennedy School of Government at Harvard. She also, I should say, is known for being Bob Dole, Senator Dole's chief of staff for 10 years, being a leader on the Senate Finance Committee staff. In 1995, she was elected Secretary of the Senate, the Chief Administrative Officer of the U.S. Senate, and she has served on many important bipartisan Institute of Medicine and other types of panels that have made major, significant, and influential recommendations about healthcare in the United States. Sean Cavanaugh is the Deputy Administrator and Director of the Center for Medicare at the Centers for Medicare and Medicaid Services. He essentially is running Medicare on a day-to-day basis for the federal government. Sean is also, I understand, a graduate of the school here, and worked in Maryland as in the in the commission that sets hospital rates before he moved on to his incredible federal career. Our third panelist is Jack Ebler, who worked for Congressman Waxman during the period of time that the Affordable Care Act was being developed. And he is also a senior health consultant and advisor working with the Institute of Medicine, with the Inova Health System and the March of Dimes and other major healthcare organizations, as well as being one of the senior trusted advisors that people turn to as they're trying to figure out the future of healthcare. So it is really a tremendous group. And what we're going to do with the time that we have left, I'm going to pose a brief question to each of them, and then we're going to facilitate a discussion with the panelists, and hopefully maybe with a couple questions from the audience. And maybe I'll start with Sheila Burke, if it's possible, given your encyclopedic understanding of Medicare and the various political considerations from over the decades. What do you think the major lessons are for health policy from the 50 years of the Medicare program?
Oh my. Well, thank you. Thank you for sharing. It is a great pleasure for me to be here. I very much appreciate it, and to have the opportunity to sit next to the chairman. Although I worked for Bob Dole for 20 years on the Senate staff, there were times when I actually thought, and he thought, I worked for Henry. Especially during the period of time when we were expanding Medicaid by years in terms of the coverage of kids. So it is a great privilege to sit next to him and to be with my colleagues. You have asked a very interesting question and a challenging one, and I think sort of my role here may be to reflect a little bit on the history of the program and what we've learned from that history, and my colleagues, I think, will talk about some of the more current events. Most of us, in fact, don't know a world without Medicare. I mean, it's sort of always been there. As Karen noted in a terrific article she did in the New England Journal in January of this year, it has been a reliable guarantor of health care for the elderly and the disabled for a very long period of time, for 50 years for the elderly and for about 43 years for the disabled. It was born out of frustration. It was born out of desperation in terms of the exposure that adults were then facing, seniors were then facing with respect to access to care and their care. They were mostly poor, as the chairman has suggested, and without insurance. So it came out of a period of time when there was an acknowledged need for a population that were considered worthy. And so one of the lessons is when you are looking at populations and looking at coverage and looking at opportunities, is defining the population. And at that time, that population, because they were related to the workforce, they were engaged in the Social Security system, as were their spouses by reference. They were considered worthy, having contributed to that system. So they built on a system where there was a great deal of faith and commitment, and that was the Social Security system. So one is building on something that you know. It was not an easy transition. There were efforts during the 50s to try and expand coverage that failed. The 60s and the success in 64 and 65 with Medicare and Medicaid was as much a testament to the leadership of Lyndon Johnson, who was an extraordinary legislator and an extraordinary tactician in terms of his knowledge of the institutions of the Senate and of the House, and his having turned over to Wilbur Mills, who was the very powerful chairman of the Ways and Means Committee at the time, and simply saying, get it done. And so it is choosing the time to make these moves and choosing the right mechanism to do so. He chose to use the Congress in that way, as did President Obama, in terms of moving his agenda forward and moving the health care policies forward. It was for folks that were considered worthy. It was focused on acute care and hospital, because that's what we knew at the time. As the chairman has suggested, drugs were not as critical an element, and so we really dealt with what we knew about the healthcare delivery system at the time. It was largely took place in buildings, in hospitals. It was driven by docs and the orders that docs gave and the services they gave. Organized medicine fought it from the very beginning and had previously fought previous efforts to essentially move health insurance forward, suggesting it was going to interfere in the relationship between the physician and the patient, putting the government between them. The structure of the program, however, as Mr. Waxman suggested, accommodated that in the sense that it left the physician piece as voluntary. That was a tip of a hat to the physicians at the time in terms of the reality. So the second lesson is really knowing your audience and knowing essentially how to move an agenda forward. The primary group of people that were really powerful during that debate were the children of the adults who were going to be covered, were union members and the unions who were anxious to provide this kind of security. So it's also engaging with the right stakeholders in terms of moving the agenda forward. There have been changes to the program, but they have been very slow. There have been more groups covered, the disabled in 72, the end-stage renal disease population in 72, the ALS population. There were more services, drugs being one of the biggest, but we also decided to cover hospice. Finally, the movement toward an acknowledgement of where people's choices were in terms of care. The payment reforms, we started with cost, we moved to 223 limits, we moved to DRGs and PPS. There's a whole body of acronyms that we've gone through in terms of payment reform to try and move towards a system that acknowledges essentially quality and outcomes. And the use of non-physician providers. Some people use that term like hamburger helper, but as a nurse, the final acknowledgement that in fact there are lots of people participating in the system. So it's acknowledgement of what's changed in terms of the healthcare delivery system. From the time when we followed what private insurance did in the 60s to a time where we drive the agenda in terms of what Medicare does. But as Karen suggests, the program remains confusing. It is complicated for both beneficiaries and providers. So many of the issues that we see today, the ACA brought with it some opportunities for us moving forward. So the lessons about who does it, when you do it, for whom, are all critical elements of essentially how you build an agenda and how you move it forward.
Great. That was terrific. I'm going to turn next to Jack Ebler. Jack, maybe you could talk a bit about the transition point for the Affordable Care Act and Medicare. What became possible through the Affordable Care Act, and where do you see the program going in the future?
So thank you. I would just echo what Sheila said. An honor to be here with you and with this panel, and particularly with now Professor Waxman. It's as he was saying, in the context of the Affordable Care Act, Medicare was both sort of a financing mechanism. We needed Medicare savings as part of the way to finance the coverage expansions. But it also was a remarkable opportunity to kind of build on some of the innovations that Sheila and Karen and Henry have talked about to make Medicare a much more aggressive purchaser and really sort of turn to it to accelerate a lot of the changes taking place in healthcare today. And use Medicare's leverage to drive some of those delivery reforms that I think a lot of you have been working on, and of course Sean is now in the position of implementing. So it really was in the context of a big piece of legislation like that. You can sometimes do things that might not have been possible in a sort of discrete political environment. The other interesting thing, so that's underway, and the spending trend lines, and again, the spending per capita spending growth had started before the ACA, but again, it's an accelerator and sort of took advantage of that trend. I must say that if that trend line had come down by the $1 trillion, it would have made our work on the ACA a lot easier. But that's hindsight. The other thing that was, I think, interesting in the ACA that is sometimes overlooked is some tests of what I would call governance changes. One, the most controversial and visible, was the infamous Independent Payment Advisory Board, which is in theory in place if the spending trend lines had not remained under control. This board has the power to step in and sort of make it so. If anybody believes the United States Senate can confirm 15 individuals, raise your hand. So that's one. But probably more important is the Center for Medicare and Medicaid Innovation. Well, Karen and Sheila have talked about, Medicare is spectacularly successful, but it lags sometimes. It stays a little bit out of date. And the question is, can you give the executive agency more authority to make changes that are tested and proven without needing the Congress to act every 5 minutes. And that's increasingly important as the healthcare world changes, as technology changes. And so both on the payment policy, leveraging payment reform, and thinking maybe differently about governance, I think were two of the opportunities that came up there that might not have otherwise arisen.
Great. Well, that's a great lead in to Sean. Sean, thanks so much for coming. You got a very important job, and you've been doing an incredible amount of creative work at CMS lately. I think people who follow healthcare know that this is a moment of incredible innovation from the Medicare perspective. What's it like to be in the middle of all that, and what do you see looking forward?
Thanks, Josh. It's exciting to be in the middle of all of it. Before I dive into my remarks, I wanted to note that you didn't mention in the introduction, my first job out of college, I actually worked on Capitol Hill. This was back in 1987 for Congressman Ben Cardin, now U.S. Senator Cardin. And in 1987, we looked at Henry Waxman as a giant who had accomplished so much. And then that's before the next 25 years of accomplishment. So for me, it's a great honor to...
That's great. Let me just mention that Renee Cohen is here from Senator Cardin's office.
Yes, and Renee and I work together.
Yeah.
I had a growth spurt, yes. But thank you for having me here, and it's an honor to be with all the panelists. I would like to pick up on the theme that I think that I hear here, which is, in many ways, the Medicare program is in the greatest shape it's ever been in. Several have made references to slow growth in costs. So in 2012 and 2013, per capita Medicare costs essentially didn't grow at all. And if anybody had ever predicted that in 1987, it would have been unbelievable. There's a lot of factors that contributed to it. As we speak, the Medicare trustees are announcing data from last year, and I don't know whether they've spoken yet, so there's still very low growth in costs. It's roughly 2% in the last 2 years, which is still below the growth of the economy. It's just a tremendous accomplishment, not solely due to actions of Congress, not solely due to the actions of CMS, but certainly all the above, and certainly just a change in the way the health system is performing. Much of it driven by professions and trade associations, but supported by congressional and administrative action. That's on the cost side. In other ways, great progress has been made on improving the quality of care that Medicare beneficiaries receive. Before the Affordable Care Act was passed, people talked a lot about readmissions. 1 in 5 Medicare patients would go back to the hospital within 30 days of being discharged. We're now seeing, for the first time ever, and since that's been followed, that those rates are going down. Hospital-acquired conditions among thousands of hospitals across the country are going down. So really tremendous progress. But put it in the context of the enrollment figures that Karen mentioned, which is that in the next 15 years or so, the program will grow by 60% just because of enrollment, regardless of per capita, means as great a shape we're in, we face challenges we've never faced before, which picks up on Jack's comments. The nice thing is the agency, at least, has been given tools by Congress that are unprecedented. You mentioned the Innovation Center where I used to work. So first, I always like to say, I meet with private sector people all the time who say, Medicare, you're a dinosaur, you need to innovate. And I ask these insurers, how do you pay hospitals, DRGs? How do you pay physicians? Well, off the Medicare fee schedule. So in many ways, it's Medicare payment that drives private sector payment. And Medicare payment has really been developed over the years through congressional and administrative demonstration programs. We tested DRGs in New Jersey and other states, including here, before we rolled them out nationally. So what Congress did in creating the Innovation Center is say, we need to replicate that process, but given the level of challenges that we face, we need to accelerate it. And Jack made reference to this. 3 major changes that Congress made in creating the Innovation Center. One was to fund it over multiple years. So you'll hear every year about, especially with a Congress divided from the administration, are they going to get the appropriations bills passed? What is in each individual program going to be funded at? The Innovation Center is funded for a decade, regardless of what Congress does in any given year. And that funding recycles, meaning in 2019, it's automatically reappropriated for another 10 years unless Congress acts. So it gives stability, first of all. It's a lot more funding than Congress had ever provided for demonstrations and innovations before. So if you go to the Innovation Center's website, you'll see a long list of demos that are running. When I arrived at the CMS, there were like 3 or 4 demos running. I think we're over 30 now. Flexibility. Congress, and to this day, Congress dictates many of the demonstrations that CMS should conduct. But in the Innovation Center, it allowed a lot of flexibility for government, for the CMS to come up with the demonstrations. And in fact, CMS then went out to the community and asked people in the public to suggest demonstrations. And Johns Hopkins is actually conducting 2 of the Innovation Center demonstrations. And finally, and I think this was a major shift, as you said, Jack, in the past, when CMS finished a demonstration, it would wait 2 years, evaluate it, write a report to Congress that would take a year to get cleared through the administration, send it to Congress, and wait to see if anything happened with it. And now the Secretary under the Innovation Center Authority, if she can demonstrate that this demonstration was a success in improving the quality of care or controlling Medicare expenditures, she has the authority to expand the demonstration. And the statute says, including implementation on a nationwide basis. So we have a pathway for really innovating quickly and positively that we've never had before. It's an incredibly necessary tool to face the unprecedented challenges that the baby boomers present. So, thank you.
Great. Well, that's tremendous. And we have a good 20 minutes here for further discussion. Professor Davis, if there's any questions that you want to pose to the group, or Congressman Waxman, any reactions that you have to that discussion? Maybe we could start with one of you, too.
Well, it seems like in Washington, all the predictions are about the next election, no matter when it's going to occur. But how big do you see the Medicare issue looming in the 2016 presidential election? And what do you think the shape of that issue will be?
I think there are clashing philosophies about how we ought to have government involved in health care that will be at stake. Now, whether it will be part of the debate, but it's certainly going to be at stake in this next election. The budget adopted by the Congress, the present Congress, of course, their budget can be adopted, doesn't need to be signed by the president, but the enabling legislation has to get a presidential signature or 2/3 vote to override his veto. But that budget provides for dramatic changes in both Medicare and Medicaid. In Medicare, Congressman Paul Ryan has argued that we ought to change Medicare into a system of premium support, where when you're eligible for Medicare, you will get a voucher for a certain amount of money. And then you can take that money and buy a private insurance policy. And if you want a better policy than what your money will pay for, then you add to it. And in that way, you can be a good shopper. The idea is the consumer can be a good consumer, make decisions based on costs, and drive better cost efficiency in the system. That would be a very radical and dramatic change, and that may or may not be talked about. For Medicaid, which was Congressman Wilbur Mills, when Medicare and Medicaid were adopted, he said, what we want is a triple layer cake. We want the layer for the hospitalization, a layer for the doctor's fees, and then something for the poverty people. So what came out of it was Part A, Part B, and Medicaid. For Medicaid, which has been a program where the federal government matches some portion of the money that's put up by the state, anywhere from a 50-50 match to an 80-20, 80 federal dollars to 20 at the state level, giving states a lot of leeway to make decisions, but some requirements on them as well. The proposal that is being put forward is to say, we'll just make this a block grant and give each state a certain amount of money and then tell them to do the best they can to take care of people who otherwise would have been in Medicaid. And some of us are very worried about that because there's no requirement to do anything except use the money for poor people and only as far as that money will take you. No requirement they put in any state dollars. So there are dramatic changes that could be made if the Republicans were united behind those principles. And so a lot will be at stake. People say, well, will the Affordable Care Act be repealed if there were Republican domination of the government? I don't think so. But what they do instead is to change the way these programs have operated. And a lot is at stake in this next election, presidential election.
Great. I'd like to open that question to the other panels, but maybe also add the idea that a lot of the changes going on in Medicare are below the political radar. You're seeing bipartisan support for them, the kinds of innovations that you're talking about. And maybe, as we're thinking about what rises to the level of political conflict, why has Medicare been so successful in not being caught in the crossfire?
I sort of feel compelled to represent the 29 Republicans running.
Go for it.
Yeah. From the sublime to the ridiculous. I think I would agree with the chairman's comment that I think Medicaid is particularly vulnerable on the Republican side, far less so Medicare. And your point about there's a great deal that's going on in Medicare that is essentially below the radar screen or that is bipartisan in nature. I mean, you need only look at the constituency and look at who votes. I mean, if you go into a primary environment or into the electoral process and look at the history of voting in this country in recent years, the elderly are an extraordinarily strong political force. If you look back to the beginnings of the program and the support of the children of their parents and unions and others, the constituency now are 50 million strong that are eligible for the program. And so I think the political realities are it is extraordinarily risky. Ryan has in fact suggested a voucher system, but you've not heard much about that of late. You've heard far more attention being given to the Medicaid program and the ability of the states to control that money, and it's on the basis of states' rights. So I think the risk in this next go-round, should there be a Republican in the White House, would be far greater to Medicaid than it would be to Medicare. I also think, with respect to the ACA, I think that's exactly right. I think it's unlikely to be a full repeal, but I think there are likely to be elements, the rating or the bands in terms of the coverage from 100 to 400% of the poverty line. I mean, sort of all those pieces, I think, might well be at risk. The issues of the taxes, whether it's the Cadillac tax or the medical device tax, which the repeal of which has bipartisan support. So I think there are elements of the ACA that could be at risk. Certainly the IPAB, which has not been appointed. But I think Medicare, because of what's taking place and because of the support of that very broad constituency, is less at risk in many respects. I mean, there are changes, how we pay providers, all those kinds of things that are inevitably in every budget package, and likely to be so again, but less so on the individual consumer side, I think. One other thing I would take 2 seconds to note in the history of the program, and I know this is something Karen's noted in the past, when we look at the Medicare program, we look at the extraordinary changes in the healthcare delivery system and financing and services, but there are other benefits to what occurred when Medicare passed, which we sometimes forget, and one of the most critical was the desegregation of the hospitals in the South. One of the most remarkable events that occurred under Johnson's leadership was essentially saying to the Southern hospitals, either take the money or you're out. And in order to take the money, you have to desegregate. So when we credit Medicare with all of the remarkable changes in healthcare, we cannot underestimate the impact it had on the delivery system in the South in particular, at a very difficult period of time, having just passed the Civil Rights Act and so forth. So that's another piece of the Medicare history I think that's important.
Right. And Medicare also is of some utility to academic teaching centers, I understand.
Yes, the inclusion of the payment for academic teaching hospitals for indirect and direct medical education.
Another
Quite
example.
considerable.
Okay, Jack.
The payment, even in this fine institution, one might describe as a dramatic overpayment for what they do.
Or one might not describe
One
it.
might
I mean, you
not.
know, it's a,
If I ever want to come back.
But many do.
I think the answer to your question, Josh, also goes back a little bit to what Congressman Waxman said about the ACA, where while this was sort of impugned as a socialist effort to take over healthcare, it really came out of what was the coverage piece came out of what was mainline Republican thinking. Many of the Medicare reforms did also. I mean, the whole idea of paying for value, measuring quality, was not a sort of a radical Democratic idea. In fact, many Democratic staff were concerned about paying for quality, that this was not the right way to go. So Mark McClellan in the previous administration had taken the lead on that. MedPAC had been pushing a lot of these things. So the reforms themselves came out of sort of what in the cacophony of Washington was truly sort of mainline policy thinking. And second, I think the administration has done a very good job in implementing the changes without sending up red flags. There could be something later today. You never know, Sean. So don't turn your back. And third, the fact that the rest of the ACA is so controversial in some ways all the political fire goes elsewhere, and so the
Not to
Medicare
Medicare.
kind of does get to travel underneath the radar screen a little bit, which is a nice luxury.
So just briefly, I concur with Congressman Waxman, which is to the degree privatization were to arise, I think it would be divisive among the Democrats and Republicans. It would become a very partisan issue. Concur with my other panelists that on the delivery system reform, there's been remarkable bipartisanship. Most notably, and not many people have connected these dots, so Congress, in an overwhelming bipartisan majority, recently repealed the sustainable growth rate formula for physicians, very unpopular, but in it also essentially created a new program where physicians can get bonuses for being in alternative payment models. Well, alternative payment models in Medicare only exist to the degree the Innovation Center created by the Affordable Care Act create them. So essentially an endorsement of the delivery system reform ideas in the Affordable Care Act, not explicit, but very embedded in statute now.
You might not want to share that.
It's just among us.
Yeah, just in this crowd.
and all the people who will watch later on the
Right.
internet. Yeah, no, sorry. So, but I think it is in fact true, and people would say that the types of innovations that the Innovation Center has put forward have been incredibly popular in red states as well as blue states. And when I was the health secretary, among my Republican counterparts, incredibly popular. And it doesn't surprise me that there was support for those sorts of things in a bipartisan way. We have a moment maybe for a couple questions from the crowd. Scanning. I think I see Professor Anderson.
So the Medicaid program was created.
Yeah, maybe if you could speak into the mic.
I'm loud. The Medicare program was established as a health insurance program. But now if you look forward, it's people with multiple chronic conditions, with disabilities, with a lot of social needs, as well as healthcare needs. Is the Medicare program going to transform to being something that accepts and understands the social needs of this population as well as the medical needs?
You raise a very important point, and it's one that we've struggled with, and that is the acknowledgement that maintaining health isn't necessarily all about healthcare. It's about a whole variety of contributing factors, from nutrition to housing to a variety of other issues. Medicare has been loath to get into the social welfare business. Medicaid has put its toe in those waters, but Medicare has, as I suggested, begun in buildings and only slowly moved outside of buildings, and is really only in recent years begun to acknowledge the importance of community-based services and the value of home-based services. We saw in the last few days an acknowledgement in the hospice benefit about the ability of people to sort of test out whether they can manage between both traditional institutional services and hospice-based services, and whether they improve as a result. So I think that there is fear about crossing that line and beginning to cover things that are not defined as health services and how broad that definition goes. But we've really successfully ignored the whole question of long-term care for a very long time and the financing of long-term care. As the chairman suggested, it's largely been post-acute, 3 days, limited home care benefit with very little that acknowledges that people are chronically ill. We're caring for people now at home that I could not have cared for in an ICU when I was in practice. And so the program has very grudgingly begun to move in that direction, but I don't think you're likely to see a big rush anytime soon, particularly given the exposure to the program and the trust fund if we were to begin to get in that business. But the Innovation Center, and Sean may want to comment on this, on the deal with the duals, with those that are eligible for Medicare and Medicaid, I mean, I think there's an interest in looking at how they are managed between the two programs, between the feds and the states, and how we can improve their status, many of whom are chronically ill and certainly high utilizers of service.
Yeah, so I'm going to say that it is an area where we move with some trepidation, but there's a step short of that where we're moving aggressively, which is trying to incentivize providers to work better with social service organizations without bringing the social service organizations under the Medicare benefit. Examples would be in accountable care organizations or primary care medical homes, or even in some of our bundling models.
I can think of an example in the state we're in.
Please do.
Yeah, the fact that when Sean was at the Innovation Center approved a waiver for Maryland to be able to shift off fee-for-service payment and essentially have hospitals incentivized for fewer preventable admissions was extremely important in this regard.
So, and we have seen that in other models where providers, once they see that their financial incentives have changed and that they're accountable for some, total cost of care, they on their own then begin trying to build these bridges with social services. They universally report it's incredibly difficult. It's something they're not trained to do, something they don't feel like they do well, but it's the beginning of this.
Jerry, the other thing you have to think about there is the tacky subject of taxes. I mean, you cannot sort of, you looked at the data earlier. We grow, from something like 56 million beneficiaries today to 80 million in 15 years. We can do all we want in slowing the rate of growth. We're going to need new revenues to finance this unless we have a dramatic change in the social compact, just the current program. And so to get into the next things is going to require sort of some taxes beyond that. So you really have a whole tax and revenue debate that the health policy community is in part dependent on to even begin to get into some of those discussions.
But back to Sean's point, I mean, an area where we have not done well, and I can say this on the provider side as well, is in the transitions. I mean, in essentially the point of discharge to essentially post-acute environment, that hasn't been owned by the hospitals as much as it should have been. So the efforts on the part of the Innovation Center and others to figure out how does that transition occur, what responsibility do you have when it occurs, and we're largely now incentivized by the penalties for readmission. But, the reality is, there's vertical integration going on, so you're seeing, the purchase of nursing homes and home care and a variety of other things. But that transfer point is so critical. Are they going to the right place? Do they have the right support systems in that place? Even if we were to simply improve that, it would have an enormous benefit to the beneficiary.
Great, and September 10th, we're going to devote the whole day to long-term care and disability. Congressman?
In some ways, it's ironic, but a lot of what's going on in Medicaid may be very helpful along these lines, because many states are now talking to the CMS about what they call waivers. And in doing so, they're negotiating assistance from the federal government to experiment in things like that are called whole people's care, whole person's care, and trying to take away some of that segmentation of care, where we would separate the social needs away from the medical needs. And then I think in some of the demonstration projects we called for under Medicare and under the Affordable Care Act, we wanted to see how we could be more effective in dealing with people with chronic care problems. So when you deal with people with chronic care problems, we obviously were thinking they shouldn't have to go to so many different providers of care. They ought to have some consistent, coordinated care to deal with their chronic needs. But I think that opens the door as well to figure out how to fill in some of the gaps. The most expensive things may have to wait. One of the things I'm excited about doing here and learning here at Johns Hopkins is the work that many of the members of the faculty have been looking at to see how we can deal with long-term care, change Medicare to cover some parts of these services. Maybe it's the transitions. But I think we're moving more toward looking at a system-wide approach that won't specify each service, but addressing the needs of the patient or person overall.
Great. We have time for one other quick question, maybe. Go ahead.
Hi, I'm a master's student here at Hopkins. Speaking of chronic diseases, my understanding about the ACA is that there is kind of this movement towards more prevention. And so I just wanted to get a sense of whether this is on the agenda of Medicare to have more reimbursements or programs targeted toward counseling for patients and patient education. And if that is or isn't on the agenda, what are some of the barriers that are preventing that from happening?
Maybe Sean?
Sure. Thanks for that question. If you mean prevention in the true sense of prevention, there's statutory limitations. There's very specific preventive benefits we cover. If you take a more expansive view and about care coordination and prevention, we've been taking steps in Medicare by creating new payable services for physicians, like what we call our chronic care management code. So a physician can bill Medicare for spending time in his or her office talking to other physicians to help coordinate care for a beneficiary without having the beneficiary come in for a visit. We interestingly, just a couple weeks ago, proposed paying for physicians to sit down and spend time with beneficiaries talking about advanced care planning for the first time in Medicare. Well, not for the first time, but that explicitly in Medicare. So we're seeking opportunities to reimburse the type of care we want to see, which we don't think of as true prevention, but it can be sort of secondary and coordinating type function. I think true prevention is an area that Medicare, like social services, moves with some trepidation and with a fair amount of statutory restrictions.
Great. Maybe I'll give Professor Davis and then Congressman Waxman the last word. Anything you want to say, Professor Davis?
Well, I would just say it's an exciting time to be in healthcare. So it's a particularly exciting time to be a student in healthcare and prepare yourself to be the leaders that will really move the healthcare system and move health policy forward. It's exciting to be in the faculty and doing research, to see this openness to change, openness to innovation, increased opportunities. I think there just couldn't be a better future to engage talented people like we see around here every day.
Well, I want to echo that. I think this is an exciting time. There's a lot going on to change the direction of healthcare as we used to think of it, and try to experiment, demonstrate, learn from what works and what doesn't work, and then apply it elsewhere, and to push the boundaries to see how much can be done with as little money as possible sometimes, but at least push the boundaries and not just think about paying for every service, but to treat the whole healthcare system in a comprehensive way, not a segmented way. On the interview this morning, I talked about how we used to, in some ways still do, but we're getting away from it, segment people selling for mental health services from physical services. And of course, there's no real clear distinction between the two. And some of the what are called non-medical services are in fact related very clearly to the medical services, and we need to figure out how to integrate those in a way that makes sense.
Great. Well, this is we're at the Johns Hopkins Bloomberg School of Public Health in its 100th year, in the 50th year of Medicare, and the first day of the Centennial Policy Series. So please join me in giving a huge thank you to our panelists and to Congressman Waxman for joining us.